with glue applied over it to stop the leakage. This glue, however, got smeared over the keratoprosthesis and had to be scraped, increasing the already existing double trouble. Subretinal gliotic bands were removed, followed by laser photocoagulation, and perfluorocarbon liquid silicone oil exchange was done. Finally, the corneal transplant was completed. At 6 months follow-up, there was a well-attached retina with a vision of 636 N36, and this made the patient ambulatory. I present a 23-year-old female patient with diminution of vision, pain and redness in the left eye for last 1.5 months. She also gave a history of wiping her face with a towel while sitting on a hilltop. The best corrective visual acuity in the left eye was 6/9 N8 with multiple linear foreign bodies in the anterior chamber and deep corneal stroma. She underwent an anterior chamber wash with removal of multiple linear foreign bodies and was found to be stable post-operatively. She, however, had recurrent episodes of vitritis with a drop of vision which would respond to oral steroids, however, recur on stopping them. There were extensive exudates in the pars plana with peripheral tractional retinal detachment and vitritis. Ultrasound biomicroscopy showed thickened pars plana with multiple hyperreflective linear structures suggestive of query caterpillar hair. She was planned for a pars plana vitrectomy 3 weeks after a 360-degree laser photocoagulation. She underwent an encircling band and a lensectomy was done, sparing the anterior lens capsule. PVD induction was done and the vitrectomy was completed. There were peripheral retinal detachment with posterior laser chorioretinal atrophy which was well seen. Multiple caterpillar hair were removed from within the exudates in the pars plana, leading to a few retinal breaks. This was followed by fluid air exchange and laser was done to the retinal breaks, followed by silicone oil injection. 3 months later, she underwent silicone oil removal with secondary IOL implantation. Her last follow-up at 2 years showed a vision of 6/9 N6, which she maintained in the left eye with no history of recurrence of inflammation. A 17-year-old boy, ambulatory till 5th standard with his right eye, now had PR inaccurate vision following an injury with a brick. There was chronic retinal detachment with extensive PVR. The way we have formation of icicles due to a temperature difference, we can have retinal icicles forming due to a variation in the pH. Presenting retinal icicles. Pars plana vitrectomy was done. A peripheral retinal break could be appreciated with discolored subretinal fluid coming out from it. Perfluorocarbon liquid was then injected over the posterior pole of the retina and more fluid was drained from the pre-existing retinal break. More perfluorocarbon liquid was then injected. Peripheral retinectomy was performed after doing a diathermy. Several crystals resembling icicles were seen on the outer surface of the retina. I tried plucking a few of these crystals, but soon realized it was a task impossible. The exact pathogenesis of these crystals is obscure, but a possible cause is the pH elevation in a detached, degenerated retina, causing calcium oxalate crystals to deposit. The tautness of the retina could be appreciated. The pedicle was then detached, and a 360-degree retinectomy was completed. The edges of the retina were then trimmed. A relaxing incision was made and the retina flattened. This was then followed by endolaser photocoagulation, followed by silicone oil PFCL exchange. The retina was found to be well attached post-operatively, and the patient gained a vision of 5/60, which again made him ambulatory. And with the help of low vision devices, he was able to read large letters. So never give up.
Thank you, Dr. Manisha, for such wonderful cases. So the session is now open for discussion on these 4 topics. The first one is cysticercosis. So anyone has it? So why did you use PFCL to push away the cysticercosis?
Basically, the cyst was subfoveal. And you're not really wanting to do any kind of an intervention because that is going to ultimately have an impact on the final visual recovery. So PFCL is basically a bubble, a heavyweight bubble, which is being used to displace the cysts away from the foveal area. So one option is that you make an opening right over the cyst and take it out, but because it was subfoveal, I thought it is the best that I take it away from the foveal area and then do my maneuver.
So sometimes, can't it happen that the PFCL just sits over the cysticercus and does not allow it?
So what you have to do is that you have to gradually increase the volume of the PFCL so that it is, having a tendency to push the cyst towards the opening. So if you are going to initially place a very large bubble, then it is going to be sitting over the cyst and not allow it to move. Here what we are trying to do is we are just trying to tell the cyst to move in a particular direction and using the weight of the PFCL bubble to direct it towards that side. But what you are mentioning is very right. If you will put a large volume, then it is just going to be, sitting over the cyst and not allowing it to move.
So a second case was keratoprosthesis and RD surgery.
Yes.
So anyone wants to ask? Sir? Okay. So I think that was an excellent case. One thing is the graft that you use post-operatively because of the silicone oil. What measures generally you take to avoid the silicone oil touching that graft?
It is a little tricky situation because after you've done your VR surgery, you're going to be placing the silicone oil, and subsequent to that, you will surely have the leakage of the oil when the graft is being placed. We usually don't put in any measure or take any measure to avoid the silicone oil from coming into the anterior chamber. But yes, I do have a few patients, maybe 2 patients, where we knew that we could never take out the silicone oil in those cases because otherwise they'll have a redetachment. In those particular patients, we have used the silicone oil retention sutures. But the retention sutures are going to be useful only till the time the silicone oil doesn't emulsify. The moment the oil starts emulsifying, you'll again have the oil coming into the anterior chamber. But if you know your retina is well attached and you will subsequently be able to do the silicone oil removal, oil for a few months is not bad for the cornea. It doesn't really decompensate the cornea, and the corneal graft remains quite clear.
So any role of heavy silicone oil?
Not really. If my retina is well attached, I use the same silicone oil, 1500 centistokes oil.
So your third case was another interesting case, caterpillar hair. I have never encountered anything like that. So any comments on?
I think caterpillar hair removal I've done with Dr. PB sir, and
okay.
You have to find the this here actually, they're embedded in the conjunctiva into the orbit. So
Right.
you need to take out all these here. Otherwise, you're likely to end up more and more into inflammation.
Absolutely. So it's interesting. I mean, once I encountered this case, I reviewed the literature. And what usually happens is that when these cases present, we think that these caterpillar hair are only in the conjunctiva and cornea. And they are. Initially, they are. But because they are like sharp needles, with the movement of the eye, then they gradually go through the sclera and sit in the pars plana area. So these patients will keep coming back with the vitritis. You give them oral steroid. The moment you stop, they'll again come back with a recurrence. So I think in these patients, UBM plays a very important role, where you can actually locate these caterpillar hair in the pars plana area and, around the ciliary body. And as you rightly mentioned, till you don't take out all the caterpillar hair, the inflammation is not going to subside. So here also our corneal surgeon thought they've done the job by removing it from the conjunctiva and cornea, but the patient a few months later kept coming back with the vitritis. And that's the time when you realize that they've gone much more posterior than what we thought.
And most of these patients, they have late presentation, means
Yes.
late coming to you.
Yes, absolutely.
Because they have history of 1 or 2 months.
Yes.
They didn't go to any doctor.
Exactly.
This is exactly what happens
Yes.
in such cases.
And because there's a lot of inflammation in the eye, to locate the caterpillar hair within that dense exudation also becomes a very difficult job.
And the last case, again, I think it's an amazing case. I've never seen anything like that. Was this a bilateral thing or?
Yes, other eye was a thicycle eye.
Isis. So
Yes.
same. Or do you? Can it be attributed to some kind of systemic?
Maybe. I really don't know, but we were not able to really locate what is the cause of a bilateral, maybe a Stickler's in this patient. But because this was the only eye which had some visual potential, we thought let's give it a try.
So anybody was.
In a non?
This was.
These are calcium oxalate crystals. Yeah. I also sent the sample of that crystal to the lab. Yeah. Yes.
Yeah. I
Right.
think it happens when the tissue is getting dead, basically.
Yes. And it. Right.
Thank you, Dr. Manisha. It was such
Thank
an
you,
interesting.